and that will come back to me, so I'll be able to post it.
Excellent, thank you. Kia ora koutou, ko Moira Smith Tokoingoa. I'm a Senior Research Fellow in the Department of Public Health at the University of Otago in Wellington. I'm also a registered dentist, and it's a great pleasure and privilege, thank you, Nairi, to be able to introduce my colleague, Professor Linda Slack-Smith. Linda's here on sabbatical, and she's been travelling up and down the country these last couple of weeks, so it's been a real pleasure to spend some time with her. Linda is a social epidemiologist at the University of Western Australia and does a range of projects with qualitative, quantitative and translational research with her team and other collaborators. Her work is particularly focused on disparities, health equity, with a focus on oral health, and she's been working in the oral health space for a number of years now. She was recently awarded the Distinguished Scientist Award for the Geriatric Oral Health Research Group at the International Association of Dental Research, which is a very prestigious award. So I will leave everything else to Linda and welcome Linda. Thank you very much.
Thanks, Moira. I just want to acknowledge the people in the room, virtual and here. It's just wonderful to have people together that are interested in this topic, unless you've got them here by some other means. So that's very heartwarming. And look, it's been an absolute pleasure coming over here and getting to spend time with wonderful people, including some new and some we don't know. So my name's Linda Slack-Smith from the School of Population and Global Health, as Moira said. And I recognise I'm a white woman of privilege, and I acknowledge the privilege has done me well in terms of an education where my parents never finished school, but I also apologise for that privilege because it shouldn't be special for some people. So I acknowledge the custodians of the lands on which my team work, the Noongar Whadjuk people, and pay my respects to elders past, present, and share my aspirations for those of the future. I also acknowledge the Indigenous Maori populations of this area. This is Cottesloe Beach. They're planning to use this beautiful spot close to my heart, spending my childhood here for high rise. But until they do that, when we have people visit, so if you come and visit us in Western Australia, we'll take you to a coffee shop just near here and introduce you to our Aboriginal colleagues, because that's what we think should be the first thing that we do when we get people of expertise coming to WA. So this is Cottesloe Beach. I just want to acknowledge the lives lost during COVID, the pandemic that's not yet over, and the many lives devastated, children left without parents and so on. I acknowledge the impact on public health people. And I'm thinking today, you know, those working in geriatric situations, those working in aged care, who had to go in and face enormous risks only 4 years ago, and it's largely now being ignored. So times of immense change, and it's changed all of us, I think. And I also want to acknowledge this has put public health at a crossroads. I'm not really sure that the pandemic has strengthened public health. I think in some ways it's made other power in health circumstances more explicit. So I do think public health is at the crossroads. Okay, I've got no conflict of interest except winning by meeting amazing people is good for all of us. I've got a few adjunct positions, and our funding, we've been very lucky working with Moira to get some funding to come visit New Zealand and to bring Moira back over to Western Australia to really look at ways of collaborating, learning from what you guys are doing here, some amazing work, and just being able to share with people that are good value. I think research should be done for information, instruction, advantage and welfare of everybody. So I'm quite clear about, I guess, the values that drive that. And I'm a huge admirer of Nancy Krieger. I've danced with her, but I've never been brave enough to ask her a question. This is being recorded, isn't it? Oh God. She says that her mentor taught her to think critically about science, to do science critically, and to challenge when our biology is invoked as an excuse for injustice, and think expansively about people's health. And I just love that. So my background, I'm a bit of misfit youth in here, doing various things. Relevant to today, I was president of the Geriatric Oral Health Group in the International Association of Dental Research, which is an amazing group of people internationally interested in the area. Also, locally, I was on the Frail Older Oral Health Working Group in Western Australia, led by the Chief Dental Officer. And that at the moment is actually, just shut down until it got, but that's really sad. I'm travelling around New Zealand with my colleague, Associate Professor Angela Jury, who's been an amazing collaborator in much of the work I'm going to talk about today. Angela's an anthropologist and just brings a critical lens to the things that we're doing. And these are a couple of papers for which she's won international awards. And while not on oral health and ageing, they also exemplify issues that are really important to the topic I'm talking about today. So one of them, the first of the 2017 paper actually looks at racism in services for Aboriginal children, and there's some issues there that are obviously really important in care for older people. And the other paper looks at the fact we need to study up and move away from always focusing on individuals with the risk of blaming individuals and look at the structures and the systems that are behind what we do. So very fortunate to work with Angela. I acknowledge I've lost a few colleagues. Jane Chalmers was an amazing leader in geriatric oral health in Australia. She left Australia because she found the area really challenging in Australia, and then we lost her to cancer. And also 2 people on my team that have contributed to the work today, Gilda Hyman and Glenn Paley. So as said, we look at research from 3 different perspectives: qualitative, to really understand what's going on; quantitative, and we've got some amazing data in Western Australia, except it doesn't include dental data; and translation and policy. We've looked at a number of different groups, and yeah, we're talking about older people today, but older people can also be people with a disability. They can also be people with mental health disorders and homeless, and people live rurally. And when you start to compound those areas of marginalisation, you've got some people that are we don't have good data on, but we really need to think about those intersections of marginalisation. Okay, so in Australia, we spend well over $10 billion a year on dental care. Although it's said, and I should put this in italics, it's said that dental care is almost entirely preventable. If it's so easily preventable, what's going on, really? But yeah, we've got an increase in people retaining their teeth, same as around the world, and lots of complex dental work. So it makes their care really difficult. We've got an ageing profile in our population, and we've got limited dental professionals working in aged care, and I think that's probably optimistic. We've got very, very few dental professionals working in aged care. Okay, so I want to start the talk a little bit differently and just say, so who wins when we fail in oral health in older people? So is somebody making money out of this? Does someone have a vested interest? Because it's hard, and you're doing amazing stuff in New Zealand, but this area is really challenging. So who has the power? Who's stopping us? What are the blockages? Is it cultural, or is it actually, some sort of vested interest that makes it so difficult? I just think that's a really good way to think about things. And I think New Zealand might be thinking similarly in terms of smoking at the moment. Who has power? So I got very excited and immediately started thinking about donuts when I saw this. I read a competition magazine every time I catch a plane to enter to win my kids a car. They're now grown up, they've never won a car, but it seems to compensate for all my time I spend overseas. And so I got excited looking at this. It's talking about diabetes and COVID and ageing and caring about older people. And actually what it's doing is promoting pharmaceuticals. So it was a little bit disappointing. It just shows where the power might be. And sure, you want to let people know about appropriate treatments for COVID, but where's all this energy going into prevention and so on? So I just thought this was an interesting look at corporate power and influence. It reads very much like government. I also want to acknowledge I don't want to talk about groups that are marginalised, like older people, in a negative way, because we only increase the marginalisation. So if we talk about older Aboriginal people and we sort of focus on them as a sort of challenging group for dental care, it's almost like you increase the marginalisation. So I do want to try and look at things from a position of strength and positive. And I guess one of the underlying themes, what I want to say, is that we need to hold power to account. And this article is focused on children, but also in terms of elder care? Where's the funding going in aged care? What's happening in terms of providing dental services to older people and really holding anyone who has that power to account? Okay, and we have a couple of ways to live our society. And there's, lots of stuff happening in the world that might make us really reflect on our society. So there's a healthy tree. We've still got things going wrong, but less prominence with everybody and lots of nurturing, sense of community, basic needs being met, all those sorts of things. And then there's a world which is fragmented, maybe based around individuals just making a profit, those sorts of issues, and much more decimating in terms of outcomes. And really thinking about what sort of world we want and some of the things that influence that. So, for example, if people have better social connections, are they more likely to have dental care? Really simple issues like that could be really important. And this is based around children, but I just want to use this model to look at, we've either got a civil society or an uncivil society. And if we adapt this for older people, where we have equality, trust, care, we value older people. I wasn't so sure of that sometimes during COVID, where politicians would get up and say, 10 people died today, but luckily 6 of them are over 60. Didn't really feel like we're valuing the older people, but made it really clear to me maybe that I've been very optimistic, not understanding why older people weren't getting good dental care, that there were some other issues happening as well, and ageism and so on. So civil society cares about its young people, cares about its old people, focuses on prevention, is a safe place, protected environment, and so on. Uncivil society, families across the lifespan not valued, focus on material wealth, focus on cures and not prevention. I think that's something really important to think about clinically is where do we move from that focus of prevention? And I acknowledge Fiona Stanley for that thinking. So health determinants, I think everybody's heard of the health determinants. And look, a real backbone of a lot of the stuff that we do, but in terms of epidemiology, can turn into a whole lot of analysis of just describing marginalised people and what are the factors associated with things, which focus on individual, again, not the structural factors that might be to play. So, in the broader rings here, looking at things like government policy and so on, really, really important. And our work has certainly moved to focus on that. And in a recent paper, I actually talked about some of the limitations of the social determinants. And I sat and looked at the paragraph for about 2 days. So I was really frightened as a public health person to say, actually, maybe the social determinants aren't what we need, but I still seem to have a job. No one's read the paper yet. Yeah, so social determinants of health, again, all of these things are part of health and what we do. When we've got people at war, the older people aren't getting our oral health care for. We're lucky in Australia and New Zealand in many ways, but social determinants have a big impact on people's lives. Okay, so in terms of dental, there's really clear gradations between rich and poor, socioeconomic status, so in terms of oral health and outcomes. And we know that because we look at someone with teeth missing, front teeth missing, and they're homeless. That's sort of like an acceptable sign, not acceptable, but acceptable sign of someone who's being homeless. Okay, so I just want to talk a bit about some evidence of oral health inequities, some of the challenges around this work, and some of the opportunities to do things maybe a little bit different. Okay. So as I said, it's touted to be that, dental diseases are almost entirely preventable. I think we do ourselves a disservice by saying that sometimes, although prevention is definitely a way we need to focus a lot more. We spend a lot of money in Australia on dental care, and it's really challenging. And oral health in older people is a bit of a wicked problem. Although there's some criticism of using the term wicked problem, because it can just say, okay, we're going to put that in a basket of wicked problems. It's really hard, so therefore we can ignore it. We certainly don't want to do that. There's an amazing paper in dentistry that looks at the La Cascada Declaration. This is a group of dental people that got together and said, actually, we think dentistry has lost its way, and it's not really making the difference at a population level that it needs to. I ran out, shared this with my dental students, and they said, oh, this couldn't possibly be written by dentists, somebody who doesn't get it. My friend in another state did exactly the same thing and got the same response. So really interesting, but we need to challenge what's going on. So this is a group of amazing people that wrote this amazing paper really about focusing on prevention. And maybe it's not all just about dental interventions, but it's actually about using fluoride toothpaste, good hygiene and so on. Reducing smoking can be key in terms of oral health outcomes. We know the population's ageing, and ageing people are diverse. So we want to be supporting someone who's disabled, Indigenous, and so on, and from a different cultural background as well, perhaps. Huge diversity. And the other thing about oral health is it accumulates really across the life. And sometimes getting lots of dental work done doesn't bode so well when you're older. So in a purist way, we could say we're going to start and look at the best options possible from prenatal care to improve long-term outcomes. It'd be nice if we actually just saw people at 65, 70 and gave them a catch-up bundle of dental care before they got older and frailer, actually. But yeah, that would be good outcomes. And as we know, there's different ways of looking at accumulation of things across the lifespan. Either David Barker hypothesis, which talks about perinatal growth and influences on outcome, or the Kuhlmann-Shlomo approach, the accumulation of things across a life. And definitely in terms of oral health, you accumulate, I guess, damage to your teeth, but also habits in terms of eating and so on across the life. So children, if we're going to look at starting, a lot of children in Australia don't even see the dentist until they're 5 years old. And we know that those in low socioeconomic groups, so at the top of this table, are more likely to have a dental admission as children. So some kids are getting dental admissions at 2 years of age. We've got a long way to go before we can look at perfect teeth in older adults. Then we start looking at adult perspectives about oral health. And this is just a couple of interviews. It costs you money. If I'm not in pain, I'm not going to go and fork out, what, $80, it's a bit older, to go and have it checked. And again, it feels degrading and I want to see change, but I wasn't in a good mood, in good space, so I'm just not coming back. Interestingly, when we've done work with older Aboriginal people in the community, a lot of the older Indigenous people in WA will say, you've got to look after our children first. We don't want to talk about our dental care. Go look after our children and we'll talk to you. Okay, so one of the studies we did a long time ago, but it exemplifies the inequities, I think, is looking at dental visits in kids over 60. So this uses the National Health Survey data, and so you can weight it up to the total population in terms of your analysis. And we just looked at having had a dental visit in the last 12 months, people aged 60 years and over. And this just starts to show you the trends in the inequalities and what's going on. So as people get older, and some of these people have lost their teeth, but much less people, much lower proportion of people attending the dentist as they get older. And one of the striking, this is just bivariate analysis, one of the striking comparisons here is just looking at highest decile of income, wealth, and lowest decile of wealth, and just those differences in who's going to see a dental professional. And it's dental professional in this survey, not dentist. People that consider themselves healthy, much more likely to have visited a dental professional in the last 12 months than people who have poor health. And again, these sort of gradations also seen least disadvantaged, much more likely to have been to a dentist generally. If you're least disadvantaged and in excellent health, you're in one of the best situations to have visited a dentist, a dental professional. Okay, if you're someone who exercises and you're less disadvantaged, again, much more likely to have been to a dental professional in the last 12 months. Okay, so one of the things we looked at, and this was quite a long time ago, and I know there's been a lot of really good parallel work in New Zealand, is oral health care and residential aged care services and some of the barriers. And it's really nice to see some of the work happening here and see how people have got over some of these barriers. And it's about strong collaboration, strong working together. But if we look at some of these barriers, just really briefly, I'm not going to go through strong detail, but look, and I don't want to only say there's barriers, but in terms of engaging care providers in oral health, lack of protocols, lack of oral health assessments. We're meant to do an assessment in Australia when you enter aged care, it never happens. Lack of ongoing assessment, so they don't get one when they start in aged care, they don't get one ongoing. Restrictions on staff, turnover is massive in aged care, that's something else as well, and lack of experience and negative attitudes to dealing with the mouth. People would rather deal with sexually transmitted diseases, deal with someone's mouth. In terms of operational and educational barriers, aged care workers don't see dental care as a priority. They generally respond if something's really wrong. And I'll talk a little bit more about some of the aged care workers later on in their own experience of dental care. Again, lots and lots of issues in terms of just those educational barriers, not a lot of collaboration between dentists and aged care workers, confusion about consent issues if you do try and get some care, dental professionals not having training in aged care, and I wrote a paper about that a while back, but yeah, it's still not really very good. We've got a textbook coming out that looks at it as well very soon, and administrative demands and so on. And aged care, look, getting diabetic care for people in aged care, getting any care for people in aged care, maybe New Zealand's got a better approach, but in Australia it's a real struggle. And I'm talking as an individual and as a researcher. Access and equity barriers. So there's a lack of domiciliary services that will go out either to people's homes for older people or to go to aged care. I think we have one dentist and one oral health therapist last time I checked in Western Australia. That's not going to do it. No spaces in aged care, very few of them have a dental chair, and so on. Unregulated private environment that means that people are sort of under demand to earn income in other ways. Lack of ambulance transport for older people, all of those sorts of things. Geographical barriers, so very limited. I've got a colleague who runs an oral health service in rural areas about 3 hours south of Perth, but very few people doing that sort of work, going around to the aged care centres in Bunbury and Busselton, but that's the exception, not the rule. And she just said, look, Linda, I'm just going to do something. I'm going to go out and set up my own service instead of retiring. And so she's moved from having a private practice to going out to aged care facilities. Lots of research and resource barriers in the area. Again, I talked about lack of assessment, staff restrictions, working shifts, turnover, all those sorts of issues. So lots and lots of things that we found in this review that were really challenging. And we don't want to only be negative, but we need to know what the challenges are. There's also some barriers to intersectoral collaboration, and I'm really excited when I get people working in nutrition and dietitians interested in oral health in older adults. It's just, yeah, really is exciting and it's really important, and it doesn't always happen. So issues at the system level, issues at the service level, and issues at the practitioner level in terms of ability to collaborate and work together. And sometimes strong relationships and determination are really the way to get through these things. So again, we did a number of different studies looking at, so what's it like for you as a dentist? What's it like for you as a general practitioner, medico, to work in aged care and in terms of dental and so on? When we talked to the aged care providers, they had a whole lot of suggestions about how we might engage dental professionals, and this was a positive, I think. But to really enhance the collaboration, have more frequent checkup visits. So people want this to happen. It's just time and structures, I think. Workforce options, so promote awareness in dental students coming to aged care facilities. Andrew and I had an oral health therapist working with us, so we just go into aged care on weekends to look after people, and because she's an oral health therapist, she'd just be facilitating what was going on. And sometimes that's as good as it gets, unfortunately. Yeah, education, skills and training, and yeah, I think, very aware of that during COVID. if you can't get people to open windows to reduce COVID, people just don't have the training and the capacity in some of these situations to do these things. So some challenges. So we did a study that was, I think, a bit interesting. Often when you're working in aged care facilities, residential aged care, you go out to the facilities. But in this study, we actually worked with the Nigerian community. So we had a member of our team, Rola Adebayo, and she went out and she worked with the community and talked to them about working in aged care, because a lot of aged care workers in Western Australia, a lot of that community worked in aged care. And it was really interesting. So we had this assumption that the aged care workers could maybe tell the families how to deal with oral health. But in fact, these aged care workers didn't know how to get their own oral health looked after. And they didn't feel like they had very good oral health. So when you're not providing appropriate care to the carers, they're not going to be able to facilitate care for the families. So that was really an eye-opener. And it bypassed those issues of, if you talk to somebody in their workplace, they're worried about saying anything negative. So, okay. So lots of challenges, lots of work also, I think, needed in terms of social exclusion and loneliness. So for lots of older adults, they don't have that social support, so that makes it more difficult to get to services, to look after themselves, all those sorts of issues. So we're working in that sort of context. Without naming any brand names, we've also got an issue in terms of, food systems. You've got some amazing work at this university in looking at food systems better, but this doesn't do anyone in our society well. And it's really hard to take away from an older person if the chocolate in the afternoon is their one pleasure. It's very hard to take that away, but it's our society that's built up this or allowed these food systems to happen, and are based very much on profit, and certainly not on health or bit of a risk for climate change as well, really. Okay, so some important stuff to think about in terms of food systems, and maybe we'd have less people with lots of work in their older age if we had better systems. One of the issues in terms of oral health in older people is that we all work in silos, and we've got to change that. Though I used to make sure this slide was in every talk I ever gave. Lovely red earth, Western Australia. We need to realise that these problems aren't just about clinicians or public health people working alone. We've got to look at issues around income, employment, environment. Disparities in Australia are increasing. I suspect similarly in New Zealand. Education, housing. If people don't have anywhere to live, then they don't have anywhere to hang their toothbrush. Transport, getting to dental visits can be a really big issue for people, and so on. So those broader issues are really important. In terms of what's happening in Australia, we're just setting up. It's just become a limited company. I've signed my life away, I think, to set work the Network for Integrated Oral Health. So it's one of the founding members. And this is really a group of us getting together saying we've got to do this differently. We need to collaborate intersectorally to look at oral health. And I think that could be a really useful organisation. We need to increase research and engagement and include students in other disciplines. I mean, it would be good if the dental students were getting this training, but it would be also good if the medical students, the dietitians and so on, are getting training in the area. And just to acknowledge work of Janet Wallace and her team looking at oral health therapists in aged care. Really valuable models. As researchers, our research needs to be underpinned by our values. We need to empower researchers to do good work in this area. Funding them would help. Encourage boundary spanners, people that think outside the box and so on, to think a bit differently. And we need to be brave. My New Zealand colleagues aren't brave. As dental professionals or clinicians, we need to make sure we're following evidence in what we're doing. We work collaboratively, and we work with families and communities. We need to look after the dental professionals and clinicians and so on as well, because many people working with marginalised groups have very challenging work. And we need to think about the social aspects. Health, social determinants are social. It's about our communities, our values, those sorts of things. One of the things that we need to do, I think, and we've been focused on this recently, is to think about, do we just focus on the individual, telling them what to do? in which case we're telling people that are the most marginalised, you just got to do better. You're not doing well enough. You've got to brush your teeth more, eat less sugar. Or do we need to study up and hold power to account? So why are politicians making decisions and not being held to account, but the poor individual who's already marginalised is being constantly held to account by research and almost victim blamed in terms of the process? One of the things I've heard as well that came up in this study that we did is I treat everyone the same. I've asked dental services, can you do something for our Aboriginal colleagues? I've begged on behalf of particular Aboriginal. We had a couple of Aboriginal women in Western Australia that were got a music scholarship. They were great singers. They couldn't get their teeth fixed. They turned down the scholarship. And the response was, we've got to treat everyone the same. We can't do something special for a particular group. Very dangerous language, I think. So studying up. We're also looking at social practices. Now, this is challenging sociology, but it's about moving away from the individual and looking at what the collective does. So what do we do as a society? What do we do in families? What are habits that occur as opposed to just focusing on individual behaviour? And that can be more powerful because if everyone's going to the dentist every 6 months, if everyone brushes their teeth once a day, we start to understand well, what we do as a collective and what's acceptable. We're not quite sure where this is going yet, but it's certainly taking off in terms of public health papers and interest, and I think it's huge potential to maybe look at things differently. So we'd like to do this in older adults as well. So in social practice theory, we look at what are the materials, competencies and meanings behind things that we do, like eating, preparing lunch, some of those sorts of things. We just look at things a bit differently. And there are probably practices about how we deal with older people, how our food systems, all those sorts of things that we can look at. And again, this is just about looking at power and intersectionality a little bit more.
All good? I'm just listening to a Zoom.
Yeah, I think you can
You just go to audio, I think you can mute everyone.
no,
Yeah.
just there, just
Could you
Yes.
just, could you move
No.
yourself, please?
there we go. Yeah.
A bit of real life happening on the side there. So we just wanted to reflect on a couple of things. Ecosocial theory looks at issues around power, race, sexism, and the biology of health issues. And that's Nancy Krieger's theory. So I want to spend some of the sabbatical that I'm just starting actually reading some of her work so I can explore it a little bit more because I think it's absolutely intriguing. And the other area of work we're interested in here is intersectionality. So if you're Black and gay and Indigenous, probably your oral health outcomes have those compounding of marginalisation, and we need to both understand that and maybe make some things explicit that these are groups that really need more support, but also that shouldn't be special because everyone should get good care. So to really explore some of those issues. Okay, now some of the things that we've done in our work is tried to change the power balance. So privileged academics get to go to conferences that they might tell their colleagues and they might then share it with the community. Well, we took a couple of Aboriginal colleagues to a dental conference to change that power base. This should not be special, but in fact it was. And it raised a whole lot of issues with people at the conference who came up to us and said, oh, this is really interesting, it's a new approach. What we did was we took our Aboriginal colleagues to lunch, we grabbed a few key internationally respected dental health professionals, and we just shared. So our Aboriginal colleagues shared their perspective and the dental colleagues their perspective. And that's the sort of round table thing I think can be really powerful. Like I said, if you visit us in Western Australia, we'll just do a round table and get you together with people. Okay. We've done some resources for Aboriginal kids. We need some of the same stuff for families. I think they need playgroups for people with elder adult family actually, to sit around because we're all learning the whole thing individually. So there's been a call recently for some better resources for older adults. And I guess just to say that all of this work is really about our values. So Nelson Mandela said, power and inequity is not a preordained result of the forces of nature or product of the curse of the deities, but the consequences of decisions which men and women take or refuse to take. And one of my students said, yeah, marginalised people need to make better decisions, don't they? Yeah. So When I teach public health, you teach students about all the issues and so on that are going on. And they said, what can we do, Linda? What's some good? And Margaret Mead said, thoughtful, committed individuals can make a difference. The conversations people have and so on. So I'm optimistic we can do better for oral health and older adults, and keep promoting that. My philosophical inspiration comes largely from there you go, David Bowie, and yeah, I'll leave that slide out. And if someone wants to learn about some of the values I've talked about today, Google Tim Minchin UWA graduation, if you're not easily offended. And he talks about many of the values I talk about, but from a much more humorous perspective. Thanks very much, everybody.
Lots of time. Lots of times for questions. Thank you very much, Linda. It's always inspiring to hear you talk, and you know, I just see that and think we're just exactly the same things are happening here in New Zealand, and we have the similar issues, and it's very much relevant for our population. So thank you very much for your insights. So we do have plenty of time for questions. Actually, it's about 20 minutes. So perhaps questions from the floor here first.
Yes, I'd ask, what sort of public funding is there available for dentistry in Australia? Because I know it's very limited here.
It's 85%. 85% of dental care is private, and 85% of funding is private, so it's 15%. If you qualify in terms of low income and so on, then you have access to public dentistry, but you'll often in some states pay a co-payment. And one of the challenges there is until you find out what the dental work is going to be, you don't know what the co-payment is. So people are frightened to go even for the subsidised dentistry because they don't know what they're going to have to fork out. There is dental care provider. Aboriginal Medical Services get separate funding through federal government, and they provide dental care where they've got dental chairs through their dentists. They don't have a lot of funding to actually provide the dental services, but they manage to do it sort of by hook or by crook, really. Yeah, so for a long time, Aboriginal Medical Services were accepting anybody to come in and get care, but I think that's getting tighter and tighter, just funding being more difficult. Children under 5 have subsidised dentistry. For a while, we had people with illnesses, so that would cover more of the older people would get like a Medicare type funding, but we don't have Denticare, and yeah.
Can I maybe respond to that? So I am an oral health professional. I have worked. They probably can't hear you
Oh,
online.
no, this is wide for sound. Should be able to
Okay,
hear
here we
you.
go. I am actually an oral health professional. I've worked many years in that field, and have dealt with patients, most socioeconomic patients, and the challenge around it is that the funding is so limited that I have had experiences whereby not only do people actually have to dig deep to come to your practice, but that they then arrive and they also know that whatever they are forking out in terms of cost will be deducted from their benefit as well, which is a problem for me. And then because of that limited funding, you can only provide a limited amount of care. And I've had situations where people arrive, their oral health is poor, and I have to make a decision as an oral health practitioner as to what I can do for this person. And sometimes my goal is purely, can I create an environment where this person can brush and floss adequately? And that's not enough.
Yeah.
So that's, you know, that is a challenge.
I was going to say, I see plenty of people under WINS. They wait until it's bad enough that the emergency dentist will see them for free.
Yeah.
Otherwise, they just don't.
And what do you get? You get the person who sees 12 people.
Exactly.
And if you're number 13, they've been there since 5 a.m. Number 13, sorry, you go away.
Yeah.
Come back tomorrow.
Yeah.
There's one online I see, but I'm going to ask just in a wee bit of patience, Carol. So in my lifetime, I've gone from fillings to root canals to implants. With the exponential rise in the cost of each of those, should we all just put up with having gaps in our teeth?
I think current practice, dentist is really recommend to, retain teeth root. They try to restore teeth. So that's ended up with expensive dentistry service. But I think in Japan I'm from, it's covered by national insurance. 30% you have to pay. So most of the dentists always recommend keep your teeth until really, you just root remain, but root is important. That's creating another, mess in terms of how much you have to, when you have to extract. There's always, no clear answer, but at least nurses, we are the biggest workforce. Educate, engage in oral health makes, better quality of care we can do, self-care we can recommend, we can engage with public. I think slowly we change the practice, I think.
Yeah.
Oh, I was just going to say, I mean, it's the life course approach to care. And if we had that appropriate life course approach, pretty much from cradle to grave, I think we would be in a really good space in that place. The thing I think too is that dentists particularly, I think, have kind of shot themselves in the foot a little bit in terms of, trying obviously to improve people's oral health and retain their natural teeth. On the other hand, it's created an issue in terms of them having such complex dentistry that it requires quite a level of skill and care to look after that. And I think I've interviewed the 20 odd dentists who were on the oral health survey about 10 years ago. And, a number of them said, actually, we need to be brave and think about how we actually approach people in aging and oral care and think about those difficult teeth that might actually become a problem when you are 80 and have dementia, and just think about, well, maybe we need to be proactively removing some of that that need to be looked after, and so to improve what remains. So it is a challenging question, I think, for oral health practitioners as to what we do for older people for their best. Without a crystal ball, it's really difficult to tell.
It's really too.
Carol's got a question.
Oh, thanks. I just really wanted to say thanks for acknowledging that the systems approach, and particularly, food systems, because I think that we're seeing now that people, particularly in deprived environments, are getting so many more of their calories from ultra-processed foods, which are, really high in refined sugar. And just the other comment that, really nutrition status is really dependent on having good oral health status for older people, particularly in aged care, isn't it? And, a lot of those pureed foods actually just aren't as concentrated in protein and nutrients as you would get from eating whole food, which is, all part of the enjoyment of life, isn't it? The social meaning of food for older people is enormous. So anyway, thanks for mentioning about the dietetic profession, because it is, really a concern for us, because nutrition status really is just, so dependent on having good oral health.
Absolutely, thank you. I think, and like we've discussed in our discussions during this visit to New Zealand, you can't just say we're going to cut out sugar in aged care overnight, because it's people's pleasure. So, yeah. But if we had a society that reduced overall income of intake of sugar and promoted healthy meal, all those sorts of things, it would be less of a culturally ingrained issue, I think.
Yeah.
So, yeah, I think so. It's a bigger problem, and look, personally, having dealt with mother with diabetes in aged care, it was really, really challenging getting food issues dealt with in terms of that.
And in aged care too, Linda, the use of the oral nutrition supplements are very helpful, but actually some of them are really high in sugar, and often they'll have them after they've done their oral cares in the evening. So it's a catch-22, isn't it?
It is, and I think all of these things, like improving people's dentition so they can eat food, all those sorts of things can help, but it's a real challenge in aged care.
Yeah. Thank you.
Judy.
Hi, thank you so much. That was wonderful. This is going to be an unusual question because it's not something that you covered, but I think it fits into the story you're telling. My query is because I've been involved with the New Zealand Nuclear Test Veterans, and I'm aware that there are Aboriginal communities in Australia where there has been lingering impact on the environment of radiation. I was just wondering whether you'd done any research into the oral health of Aboriginal communities who are living in those areas.
With radiation exposure?
Yeah.
No, one of my colleagues in Kalgoorlie, which is I think about 6 hours drive, 7 hours drive from Perth, is a pediatrician who works a lot in the Aboriginal space. She I think she's really interested in looking at, the exposures more deeply. So things like, heavy metals and so on, and how they might impact on people's outcomes, including dental issues. We know we can look at heavy metals in people's teeth, but in terms of exposure to radiation, I don't think anyone's doing anything.
Oh, can I?
Or do you mean in terms of radiotherapy? Sorry, am I missing the question?
No, not at all. I'm just encouraging you to actually think about it.
Yeah.
Yeah, because I think, there's such a contested area as to whether there is radiation or not. And I know that it probably does impact in some way on people's gums and health. And so having some sort of evidence or suggestions of opportunities to do research would be helpful for those people who are living with the impact.
So I take that back to the causal pathways. And so if you're talking about, and I'm thinking about, traveling around the States and watching people going swimming next to the nuclear power plant. So I hope that's the sort of exposure that you mean. And I have no expertise on exposure to radiation, except remembering very dearly someone we knew who died after taking photographs of some of the tests in Australia. But the causal pathways might be that radiation might, reduce immunity and so on, increasing risk of periodontal disease and so on, things like that. Exposure to radiation might impact on your ability to have healthy nutritional intake and uptake. So again, this is from biochemistry I did 25 years ago, and only from incidental stuff. It's absolutely, but if you, I guess the first step, if interested in that area, would be to tease out causal pathways. Thank you.
Thank you.
Any other questions?
Sorry. I wanted to say thank you so much for raising this topic, because I think there is so much work to do in this area. But one of the things I wanted to ask a little bit more about is you talk a lot about oral health, which we do, but sometimes I feel like our messages aren't basic and simple enough in terms of there are 3 oral diseases, and periodontal disease, dental caries, and oral cancers, but we'll take the cancers out. But the other 2, how do we approach each one, and the understanding, the underlying cause of each one is quite different from the other. But they kind of get lumped in together, particularly in older populations. Periodontal disease is often more of an issue than dental caries, for example. But I don't think our messaging is necessarily tailored for people to understand the differences and how we can prevent the outcomes.
Yeah, and I think our messaging is terrible, and our application of evidence is often terrible. And I think there was a point a couple of years ago where everything that you could possibly get wrong with you was blamed on periodontal disease. And there's a beautiful editorial, I think it's in the Journal of the American Dental Association, that Mark Bartold in the Australian Dental Journal also picked up and wrote on. We've got to be really careful about not getting on this sort of these gravy trains of ideas, or yeah, it's great if we tell people if you improve your dental care, all of your health will be better. But we really need to watch evidence. And I've worked 25 years in the field, and there's some basic things I still worry about the evidence. We published a paper that critiqued some of the, basic hygiene approaches and things like that, and gerontology a few years ago. And I was scared of being sued. I was scared of being vilified, but I decided to publish it because we need to have the conversations about the evidence. So yeah, I think by clumping it together, we minimise that really critiquing good evidence to make our messages clear. And I think our messages in public health are often poor and not based on good evidence. And I'd say that is equally, or maybe even worse, so in terms of, that's not encouraging, sorry, but
No, I would absolutely agree.
sit down and critique the evidence and say, so what is the evidence about fluoride in toothpaste, and what is the evidence about oral hygiene, and
are they age appropriate?
yeah, and then have messages where people feel like they're getting something a bit intelligent, as well as a clear evidence-based message.
So sorry, and I have a second question, which is the impact. Do you know about the murder house phenomenon here in New Zealand? Older New Zealanders would know about this, the murder house. Yeah, absolutely. And I wonder how much of that. So this comes down to care that was provided to our young children many, many years ago. And it was provided without anesthetic very often. It wasn't an often pleasant environment. And children used to refer to going to the dental therapist at that point as going to the murder house.
Okay. I thought it was another dental school with a murder history, which is another story.
So, yeah, and I just wonder whether in our older populations now, how much of that impacts on just, well, in my experiences, it has been hugely impactful, but whether it is something that is considered within the public health research of older adults.
Well, that's where our social practices would be more relevant, where you're looking at family influence. And so I remember quite a while ago, an interview with someone, and she said, I've been in Australia 30 years, but I haven't done anything about my denture because I've heard they don't do good dentures here, so I just haven't done it. I think that, so people have a bad experience, that gets passed down. And often they're the people that don't go and see dentists. So nothing reverses that experience because they're less active in attending. And so they've got a negative and they share that with their kids. So yeah, I do think that's a really important, that culture, the culture of going to the dentist. Yeah.
I want to make a comment about the murder house, because every primary school in New Zealand had a little clinic, which was a dental clinic with a lady in it or a man in it. And they delivered services and screened and
Dental nurse.
all of the children. It was the dental nurse, yeah. And it was extremely accessible, even though it might not have been very popular. And now it seems that it's much more difficult for our children to actually get treatment because it's not on site. They have to go somewhere else.
Yeah.
It changed during my children's growing up.
Yeah, it's the hub-based system now.
Yeah.
Introduced, yeah.
So the school dental service, fundamentally, the principle underneath it was a good one. And of course, it came in with all the social changes that we had post-war. And because of the oral health status of our soldiers actually during the war with no teeth. So we wanted this teeth for life approach. And as you correctly say, the delivery was not necessarily in line with the principles. But you're right, Nairi, and actually the school dental nurse was part of the staff in the school, and they delivered education into the classrooms and did all those kinds of things. And then we had the reforms, I don't know, probably 15 or 20 years ago now, and changed it to the spoken hub community oral health service that we have today. And it means that people have to take their children to the dentist. Although we do have vans that go, mobile units that go out and just do the screening, but even for treatment, they have to go to the hubs. But I think that culture is changing too. That murder house is certainly not it's not part of our vocabulary anymore, which is, one of the good things that's come out of the spoken hub system. So that is certainly gone, but it does, yeah. I mean, my mother would not send me to the school dental nurse because of her experiences at the murder house, and so I went to a private dentist, and we were able. She made sure that she could afford to do that, but. That's the influence, that it was very strong cultural phenomenon in New Zealand for quite a number of years, decades of that.
I was a product of the murder house era, so I know entirely what you're talking about. I really agree with Carol's comment around the food system, but I'm also, and I've made comments before about this in these sorts of forums about your silo slide, I think sums it up perfectly, that, you know, when a dietitian is treating perhaps someone for malnutrition, their focus is on getting weight up, on getting as many calories as possible. And so oral health is right down the bottom of our list of priorities. And so I guess our challenges around being able to deliver the care that we're there to deliver, but also thinking more widely on just that, you know, increase in body mass or whatever we're looking to do. And so much of that comes down to that aged care environment. So those sweet foods, they tend to be delivered for morning and afternoon tea. How we change that sort of food system within the aged care, I think, is probably one of our bigger challenges, and then educate our students around keeping this in mind. And we don't do it well. I mean, I teach on a training program. It's not a topic that we teach at all. So there's a huge change that's needed around the various professionals that are involved in care to honour that, I guess.
And educating families as well, I think, who either are like, why aren't you giving, you know, them the pleasure of the chocolate in the afternoon or whatever, but also, and you know, this is, I don't want to get outside my expertise, but when people are getting closer to dying and often they eat less, you know, for families to keep that weight happening is important. So maybe families having more understanding of, you know, the process of aging, but not at a critical moment, but earlier, but families, again, the playgroup for people with older adults where they can talk about these things and share, could be really powerful, because then you at least would get that understanding of, well, yeah, so-and-so's losing weight, but actually this is what happens.
I'll challenge you on that, because I don't think that has to be a normal part of aging, but I think how we treat it and how we approach it really needs to have a change.
Absolutely. And look, it's not my expertise, but I just think people need to have that. And whatever the evidence is, maybe bringing families along with that as well would be helpful.
Well, and it's also something that families feel they can do, you know, bringing the sweets and the chocolate and the fizzy drinks and things like that. That's their way of showing care. I mean, my mother-in-law has this cupboard in her room in her aged care that is just full of chocolate and sweets, and thankfully she forgets they're there, so she doesn't eat them. But yeah, it just depicts, I think, what happens time and time again.
I think there was one more question.
Thank you so much, Linda. It was a very interesting presentation, and thank you all my colleagues here for sharing your thoughts on the culture of New Zealand. I'm from Pakistan, so I don't have such New Zealand experience here. I'm a PhD student, and after going through your presentation, this brings me back to the roots. Like, we have to work on the primary prevention, at the ages where we are developing habits with the young children. And somehow I feel that there is another side of mother house story, but would that be, you know, somehow be made in another direction useful in developing those good habits, teething, as my Japanese colleague here has mentioned, that it's important to save the roots, and that starts from the early childhood. Yeah, that's what I feel.
Yeah, I can't but agree that it's really important. Absolutely.
One last question.
Yeah. So thank you very much for your share your experience and the story. Actually, I didn't have a lot of knowledge about this topic, but I'm very interested in your methodology. So I want to ask you some questions about your methodology, because I made the similar problem. There are limited evidence in my topic. So I found that you plan to do the quantitative research first, and after that you come to the public health methodology like the quantitative. But sometimes we find that it's a little hard for you to find some findings in the quantitative research in the system level or the social level, because sometimes you're talking with person, you are always thinking like, oh, I found some reason in the individual level. So I want to know, so how do you translate your finding from the individual level to the social level or the system level? And these findings, how to get you to do the next research in the quantitative research. Yeah.
Yeah, and look, I talk about qualitative and quantitative in translation, but that's a very narrow perspective of what we do, and it's very iterative. So you do some qualitative work, you look at something quantitative, you go back. And I think our qualitative work has grown. So if you start out looking at an issue like, you know, is oral health in older adults an issue? And you get someone that says there's issues or they don't have the knowledge, that's important because you know there's people out there that don't. So at a very simple level, doing a few interviews in the early stages can be really important to sort of like, this is an issue, we're raising an issue. But then you have to sort of move your thinking to, again, doing that qualitative work and looking at it in terms of analysing it either in, you know, using a framework. So for example, when we look at issues around racism, we'll look at a large number of interviews and look at it reasonably, but you keep going till you reach saturation, which is you know, reasonably accepted in qualitative research. But the qualitative work, and again, huge credit to Angela Jury for this, the qualitative work has grown in our time. So, you know, what I did very early on would be quite different now. And so now, as I said, we're looking at social practices and looking at how we move away from focusing on the individual. So we've got a different question in our head than just what is your experience. We're actually trying to understand what's happening at this sort of broader level. And we're using individual interviews and observations and other things to try and understand that. So I think qualitative research can be incredibly powerful. I think you always have to sit and think about why you're doing it, what the framework is that you use. And look, when I started doing research, I hated frameworks. And now I can see that they're just absolutely so powerful and important. But you know, what underlies this, what's really going on, and what's the framework that you're looking at to really explore it. So social practice or intersectionality. So, you know, what are the issues for someone who has multiple levels of marginalisation? So yeah, I think I no longer, and I once went for a job interview and they invited me for a job doing qualitative research with an amazing qualitative research. And I said, oh, no, thanks, I'm not going to do qual. So it's been an evolution for me to really understand the power of qualitative research.
Thank you.
Can I just add just a little thing? Also, I think qualitative research can inform quantitative, just as quantitative can inform qualitative. So they actually can complement each other really nicely.
Yeah.
And I think one of the values of qualitative, and certainly in our experience, is that you can really get to the depth of getting insights on an issue that maybe isn't quite as possible in quantitative. So I think they can work really well.
Yeah, thank you. Yeah, because I found a lot of quantitative research, they always analyze the question in the individual level. Because they didn't, I don't know, maybe sometimes it's hard for the researcher to say that I talking with some person and I think the system have some problem. It's hard to get the results. Yeah, so I'm just thinking how to translate it between like the individual level, social level, system level, how to translate them between the different level. Yeah.
I think one of the big differences is that because qualitative research is so contextual, it's in a particular context, it's not necessarily generalizable to big populations.
Yeah.
So I think that's the key. And one of the key things is really describing your methodology clearly and well. It's not to say that it can't be applied in other contexts, but it's not like quantitative where, you know, it's often, you know, the findings are generalized to other populations. So
thank you so much.
So an example is we've done some interviews with Aboriginal families about use of sugar, aged care, but it answers your question. And what we can see is there's issues happening here in terms of the commercial influences. And so we want to go back and explore that further. And so just, you know, explore further with them how they understand the commercial. So you can look at structure and I think, you know, maybe we may need to make structural issues more explicit with people. Actually, this isn't about blaming you. This is about, hey, that sugar company. That might influence a lot of things how they vote, for example. So yeah, I think it's challenging doing good qualitative research, but it's very powerful.
Thank you.
It's a really good note to finish on.
Thank you.
Thank you, Linda, and it's been a pleasure to spend some time with you this week, and I'm really looking forward to kind of Thank you everyone here and who are online, and thanks to Nairi for being such an oral health champion. We always appreciate your support, and thank you to the consortium as well for hosting this event. So we really appreciate it. So thank you very much.
So I just want to add my thanks, Linda, for putting us into your timeline, and Moira for facilitating that. And this presentation will be available on the NZAG website for those who might be interested, and potentially on the See Create Age website if we can work out how to do that. So thank you again. Good, excellent.